frequently asked questions about vaginitis. What is vaginitis? Vaginitis is defined as any condition with symptoms of abnormal vaginal discharge, odor, irritation, itching, or burning. What are the causes? The most common causes of vaginitis are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. Bacterial vaginosis is the cause in 40% to 50% of cases in which a cause is identified, with vulvovaginal candidiasis accounting for 20% to 25% and trichomoniasis for 15% to 20% of cases. Non-infectious causes, including atrophic, irritant, allergic, and inflammatory vaginitis, are less common and account for 5% to 10% of vaginitis cases. Is history alone sufficient to determine the cause of vaginitis? Symptoms alone cannot differentiate between the causes of vaginitis. Office-based or laboratory testing should be used with the history and physical examination findings to make the diagnosis. What causes bacterial vaginosis, and what are the symptoms? It is caused by anaerobic bacteria like Prevotella, Mobilancus, Gardnerella vaginalis, Ureaplasma, Mycoplasma. There is fishy odor. Thin, homogeneous discharge that may worsen after intercourse. Pelvic discomfort may be present. What causes vulvovaginal candidiasis, and what are the symptoms? It is caused by Candida albicans. There is white, thick, cheesy, or curdy discharge, vulvar itching or burning, no odor. What causes trichomoniasis, and what are the symptoms? Trichomoniasis is a sexually transmitted infection that should be considered in women at risk who present with vaginitis symptoms. It is caused by Trichomonas vaginalis. There is green or yellow, frothy discharge, foul odor, vaginal pain or soreness. How is bacterial vaginosis diagnosed? Bacterial vaginosis is traditionally diagnosed using the Amsel criteria. Criteria include thin, homogeneous discharge, a positive whiff test, the presence of clue cells on microscopy, and a vaginal pH greater than 4.5. 3 out of 4 criteria are required to make the diagnosis. How is vulvovaginal candidiasis diagnosed? Vulvovaginal candidiasis can be diagnosed by visualization of yeast hyphae, on potassium hydroxide preparation in a woman with typical symptoms. What has complicated vulvovaginal candidiasis? Complicated vulvovaginal candidiasis is defined as recurrent, 4 or more episodes in 1 year, or severe infections, or infections that occur in a patient who is immunocompromised, such as someone with AIDS or poorly controlled diabetes mellitus. Culture is particularly important for the diagnosis and treatment of complicated vulvovaginal candidiasis, because patients are more likely to have an infection with non-albicans strains of Candida, which may require different treatment. How is trichomoniasis diagnosed? It can be diagnosed when motile, flagellated protozoa are observed on saline microscopy. However, the Centers for Disease Control and Prevention recommends nucleic acid amplification testing for the diagnosis of trichomoniasis in symptomatic or high-risk women. These tests have a higher sensitivity than saline microscopy and can be performed on endocervical, vaginal, or urine specimens, or on liquid-based pap test samples. What if no causes are identified on testing? There is no cause of vaginitis identified in up to 30% of women. These women may have a range of conditions, including irritant or allergic vaginitis, atrophic vaginitis, or physiologic discharge. Inflammatory vaginitis is an uncommon condition characterized by purulent discharge, burning, and dyspareunia, and should be considered in patients with these symptoms if no infectious cause is found. Inflammatory vaginitis is associated with low estrogen levels, such as in menopausal or perimenopausal women. What is the treatment for bacterial vaginosis? Treatment of bacterial vaginosis is recommended for resolving symptoms, as well as reducing the risk of chlamydia trachomatis, Neisseria gonorrhoeae, trichomonas vaginalis, human immunodeficiency virus, and herpes simplex virus type 2 infections. Shifts in vaginal flora have been associated with increased risk of these infections. First-line therapy includes 7-day courses of oral metronidazole, intravaginal metronidazole, or intravaginal clindamycin. Treatment of bacterial vaginosis during pregnancy improves symptoms but does not reduce the risk of preterm birth. What is the treatment for vulvovaginal candidiasis? Treatment of candidal infection is aimed at reducing symptoms. There are several topical azole preparations and regimens available, as well as oral fluconazole in a single 150 mg dose. All topical treatments, well as oral fluconazole, are recommended by the CDC as first-line therapy for vulvovaginal candidiasis. The choice of treatment should be made in conjunction with patient preference and previous experience with these agents. In non-pregnant patients, there is no definitive advantage of one treatment over another in terms of clinical or mycologic cure, with all treatment options having about an 80% cure rate. Topical preparations may provide more immediate relief because of the soothing nature of topical treatment or, conversely, may cause local hypersensitivity reactions resulting in itching or burning. Oral fluconazole offers the advantage of one-dose convenience without messy creams or suppositories. Oral medications may cause systemic adverse effects, particularly gastrointestinal effects and toxicity in addition to potential medication interactions. What is the treatment for vulvovaginal candidiasis in pregnancy? Vulvovaginal candidiasis is common during pregnancy. The CDC recommends that only topical azole therapies, applied for 7 days, be used in pregnant women with vulvovaginal candidiasis. Oral therapy may be associated with increased risk of miscarriage or fetal malformations, particularly at high doses. What is the treatment for complicated vulvovaginal candidiasis? For patients with severe vulvovaginal candidiasis, a second dose of fluconazole given 3 days after the first dose has been shown to achieve significant improvement in short-term symptoms as well as prevent recurrence at 35 days. A second dose did not have significant effects for recurrent vulvovaginal candidiasis. For recurrent vulvovaginal candidiasis caused by Candida albicans, initial intensive therapy with fluconazole for 7 to 14 days, in other words fluconazole, 150 mg, every 3 days for 3 doses followed by weekly treatment with 150 mg fluconazole for 6 months has been shown to achieve symptomatic relief at 1 year for most patients. If severe or recurrent vulvovaginal candidiasis does not respond to initial treatment, culture may guide therapy when non-albicans species are identified. Infections with non-albicans species are less responsive to fluconazole. What is the treatment for trichomoniasis? Treatment of trichomoniasis can decrease symptoms and reduce transmission to partners. In addition, in persons with HIV infection, treatment of trichomoniasis may also decrease HIV transmission rates to partners. First-line therapy for trichomoniasis in pregnant and non-pregnant women is a single 2-gram dose of metronidazole. What is the treatment for non-infectious vaginitis? Treatment of non-infectious vaginitis should be directed at the underlying cause. Atrophic vaginitis is treated with hormonal and non-hormonal therapies. Among hormonal therapies, low-dose vaginal estrogen preparations are available in creams, tablets, and rings. Systemic estrogen therapies are also available for patients with vasomotor symptoms. First-line non-hormonal treatment recommendations include vaginal lubricants and moisturizers. Continued sexual activity should be encouraged.
Audio Jungle. Audio Jungle.